Um, Good morning, and today this last lecture is the last lecture for nephrology, and this one is about renal replacement therapy, which is the ultimate, you can say, outcome for, if not all, but for most of the renal patients. Okay, so they have to end up in some sort of renal replacement therapy whenever someone have renal conditions which goes towards chronic renal failure or ESRD, which is end stage renal disease, right? So, what is renal replacement therapy? Um, this is simply, uh, you can say, you are providing some sort of therapy which is taking uh, up the function of the kidneys, right? So, and now the important thing over here is what, like, almost all the patients, who are approaching the ESRD or end stage renal disease, uh, of course, like many of them, they will go to dialysis, which could be hemodialysis or peritoneal dialysis, or many of them they will be receiving renal transplant, for example. Whenever it is, there is high chances that the person is going on dialysis, especially hemodialysis nowadays. So what we do, like we create a fistula, and most of the time that fistula is done on the non-dominant hand. And it is very important that a renal patient should know, and the physicians and the doctors who are managing them and the paramedical staff who are managing them must know that he is a renal patient and he is going to receive hemodialysis in the coming years, you can say. So they must not use his left hand to give any IV injections, because uh, we have to make something called as AV fistula, that is atriovenous fistula. Okay, so atriovenous fistula or AV fistula is basically formed to conduct dialysis easily, and if there is no AV fistula, we have to pass a CVP line. Okay, and by the way, when anyone is in the need of dialysis, not emergency, but when we know like the person is going to end up in dialysis, so we refer them to surgeons quite earlier to let them make a fistula, because it needs some time to get mature. I will show you what how AV fistula looks like, right? So, uh, okay, so fistula for dialysis, um, this is how they make it. Okay, they basically connect an artery and a vein. Okay, and how it looks like in reality is like this. And because the blood from the artery is directly going into the vein, so there is a heavy blood flow over here, and you can auscultate this area, and you will heard that sounds of blood running through that, like zzz, zzz, zzz. So we can hear that blood running in them, right? uh, so we refer them for fistula formation, and you can see over here, see they have inserted this line inside that fistula, they have connected the person from, okay, so see, this is also AV fistula, right? Again, this is like, of course, so we simply send the patient to form AV fistula, right? So that, dialysis can be done. You can see over here a lot of patients, and yes, of course, if the fistula is not there, then we have to pass this line, CVP line, central venous pressure line, CVP line, of course, like, and we of course do go for fistula formation, and then we wait for the fistula to get mature, and once the fistula get mature, of course, then we can conduct the uh, dialysis from that. Okay, a lot of photographs you can see. This is again like how they had done the fistula, right? So anyhow, I will tell you the indications for renal replacement therapy. So whenever you can say, uh, when the renal replacement therapy is needed, okay, so what are the indications? Indications, I'm talking about renal replacement therapy or dialysis, okay, they are the same thing, or kidney transplant. So of course, like when the kidneys fail to, or inability to control uh, uh, volume status. For example, if someone have pulmonary edema, inability to control blood pressure, if they have anything like serositis, like pleural pleuritis and things like pericarditis, things like this, right? If they have acid base abnormalities, acidosis, or whatever is going on, when they have pleuritis, so of course, like all the things shows like the things are accumulating inside the body, nausea, oblique vomiting, as well as deteriorating nutritional status or cognitive impairment. Okay, so then of course, like uh, we think about renal replacement therapy. So renal replacement therapy is used for, of course, dialysis. Of course, dialysis of two types. One is called as peritoneal dialysis. One is called as hemodialysis, and one is called as renal transplant. So, by the way, it's not like this renal replacement therapy is not the right word, because dialysis cannot perform all the functions of the kidney, but yes, it do clear all the things which are extra in the body and make the patient symptoms free from the kidney failure. And of course, like the renal replacement therapy is always given when the person already is at end stage renal disease, or the GFR is less than around 5 to 10. Okay, or sometimes like when we are waiting for the transplantation. Okay, and then we put the patient on dialysis. Okay, and transplantation itself is a renal type of renal replacement therapy. So what is renal replacement therapy is, you can say, hemodialysis, peritoneal dialysis, or renal transplant, right? So of course, like all these are the renal transplant, and the basis is same. The blood passed through a semi-permeable membrane, and there is a dialysate fluid, on the other side running, which basically there is exchange of the things. So, and dialysate, of course, like they prepare it, uh, especially to make, what you can say, the blood lose its all the nitrogenous waste, or creatinine and urea and the extra electrolytes and the extra volume, And of course, like in general words, the people say like cleaning the blood, but of course, and of course, like the dialysis machine is a very complex machine. It have blood pumps with blood pressure monitors with bubble detectors, and the blood flow through the pipes and through the disilate, usually at 500 milliliter per minute. And of course, like while passing through that, and the people they have to uh, connect with the dialysis over a long period of time. You can say, I will show you uh, hemodialysis, right? So this is the basics. They are showing you the basics over here, how the things work, like this one, or wait, I will show you some. Sorry, yes. So see, like the blood is going through here. This one is like the atrial pressure monitor, heparin infusion. Then there is a blood pump which is pumping the blood, which is passing through a bottle which have a disilate fluid, right? And the fluid is going from here and coming out from here. And there is venous pressure monitor, and there is again air bubble trappers over here, and then the clean blood is returned to the patient. Like this is for patient education, of course, right? So, and this is the whole circuit they are showing you. Okay, so this is like the catheter in the neck, or if we have AV fistula, so they can do it from here as well. So, and how the machine looks like is like this, uh, like of course there are many models, but like newer models or models, so there are many types, many models, so nowadays, more sophisticated models are also there. And then there is something called as peritoneal dialysis as well. So in that one, what they do, you can see over here, they pass a catheter, and they put the disilate fluid inside, and it basically from peritoneum it is collected back. So here the peritoneum is acting as a semi-permeable membrane. Okay, it have its own side effects. The other one have its own side effects. It is not so efficient, and the other one is like more efficient. I will discuss, like we will discuss what you can say, uh, the thing in detail. Okay, because this one you can do, like the patients they can do at home, but the other one, of course, specialized the machines are there, and of course, like that one is more expensive. This one is cheaper. So everyone have its own, you can say, uh, uh, benefits or advantages and disadvantages, right? Or pros and cons simply. Okay. So simply, when the patients they connect with the dialysis machine, right? Uh, they take something called as dry weight. So this is the weight when the patient is not fluid overloaded or fluid depleted. Okay. So they always do the patient weight at the start of the dialysis, and then they also do the weight of the patient at the end of the dialysis, just to make sure like the patient is carrying the right volume of water which they should have take. Okay. And of course, like uh, whenever they go for dialysis, the aim is to remove the uremic metabolites and the excess fluid in the body. So the person they have to go for dialysis like 3 to 4 times every week, and they have to stay with the dialysis machine for 4 to 5 hours. And depending on how much the renal function is still conserved, maybe someone there are patients who need dialysis like 2 times every week, or there are patients who need what you can say 7 times every week. There are patients who need like 4 times every week. So depending. So nowadays, of course, there are a lot of newer type of things are also there. There is something called a short duration dialysis also available. So in which like they use uh, high flux membranes, in which like the transport is going on at an increased rate. So simply, To talk about, to start with, we will start with hemodialysis, right? Hemodialysis. Okay. So, as I show you, like the blood is passed through a semi-permeable membrane, and there is a disalate fluid which is flowing into the opposite direction. Again, like if I'll show you that one, that that diagram again, uh, hemodialysis. If you can see over here, for example, this one, the blood is flowing through this direction, okay, and the disalate fluid is flowing in this direction, or a very nice one, this one. See, the disalate fluid is flowing in this direction, the blood is flowing in this direction, right? So this is how they do this one. So you can see the blood is flowing, the disalate is flowing, and the disalate in the blood, and there is diffusion going on both sides, of course, right? So this is the basis of this thing. And as we know, like the diffusion of the solutes, they occur down the concentration gradient. So uh, basically, what they create a hydrostatic gradient, okay, to clear excess of fluid. Okay, so this is what is the main theory about for this thing. Okay, so and whatever is required, of course, they remove that. So how we take the excess, depending on the patient. If the patient have AV fistula, that's fine. Okay, if there is no AV fistula, the excess is taken by central venous line, CVP line. They pass a CVP line. If I show you that neck, the catheter which is passing through the neck. So when there is AV fistula, of course, there is increased blood flow through that. So that's the main point. So we refer the patient to make that fistula. If someone is going toward ESRD or end-stage renal disease, we ask the patient to go to the surgeons and make a fistula beforehand. Okay, and because it needs some time to get mature. So why? Because if we use, for example, CVP line, there is increased risk of infections through the CVP line. For example, infective endocarditis can be there. By the way, by dialysis, there can be infective endocarditis. Okay, and I told you like how much hemodialysis is needed. Hemodialysis is needed depending on the depending on the renal functionality. Functionality. What is left, right? What is left, like, but on an average, you can say it is 3 times per week. Usually, it is 3 times per week. Okay. So, so this is the thing, and there are different type of what you can say advantages and disadvantages of hemodialysis, right? Of course, like there is a lot, what you can say advantages and disadvantages. By the way, I can open this thing somewhere here because we'll found it. Advantages and disadvantages, right, of hemodialysis. So you will see over here the advantages and disadvantages of the hemodialysis versus peritoneal dialysis, right? So, sorry, wait. Okay. So you can see over here that hemodialysis, the advantages are effective removal of the waste products can given by trained professionals. Like in this one, like the care is given by the trained professionals, and there is regular contact with other patients, rapid correction of electrolyte imbalance, no equipment to store at home, and treatment usually occurs only 3 times a week. And what are the disadvantages? We need vascular access, so the surgery is required, and use of large needles, schedule inflexibility, must travel to center 3 times a week, and cramping with ultrafiltration, and risk of bacteremia with tunnel, what you can say, catheter. Whereas peritoneal dialysis, okay, I'm going to discuss this thing in a while, but the important thing over here to mention is these are not the medical advantages and disadvantages, these are more like social type of things, right? So, this or the risk factors, of hemodialysis, right? So if you will see, hemodialysis have a lot of risk factors. One is like low blood pressure is there, okay, as well as so hypotension can occur. Uh, there is what you can say thrombosis can occur, infective endocarditis can occur. So there is what you can say uh, a lot of uh, a lot of adverse effects are there, right, of this one. Okay, so okay, I'm just trying to find out like if we can find something good, but I think no. Okay, so to tell you like that the risk, the complications, okay, of what you can say this one could be anything like starting from hypotension, okay, of course, because uh, if for example if someone is um, okay, by the way, but what we can do is like we can first of all discuss peritoneal dialysis, okay, peritoneal dialysis, and then of course like we can talk about the risk factors together, like the adverse effects or complications together. So as I told you, like it uses peritoneum as a semi-permeable membrane, right, to like which act for the diffusion. So what they do, like they pass a catheter inside the peritoneal cavity and they infuse the fluid, and the solutes they diffuse slowly. So like remember, it's a slow process. So the solutes they diffuse slowly, right? So it's a slow process, guys. And we have to achieve ultrafiltration, right? We have to remove excess water. So how we remove ultrafiltration? Ultrafiltration is what? Of course, like we have to remove the excess of water. So how they achieve ultrafiltration is like because the disilate they use, they put osmotic agents in them. Okay, like which makes sense why like glucose or like big polymers of glucose they put in that, and of course like they are the one which are going to suck more and more fluid out from the body. Okay, and of course, it's a continuous procedure in which the fluid is going inside the peritoneum as well as coming out, so it can be done at home. Okay, so this is the thing. Of course, like there are many side effects, like or the risk, like what you can say, the problems with this one as well. For example, there could be catheter site infection. Okay, because in the home, my like the people they are not so much careful. So catheter, sorry, catheter type site infections can be there. Okay, and or there could be peritonitis, right? Like the peritoneum can get that one. Hernia can be there because it is abdomen is there, right? And of course, like with time, what happens like the membrane function of the peritoneum can be lost as well. So you can see over here the peritoneal dialysis. Advantages is like schedule flexible, easy to travel, few risk of dialysis associated cramps, and clinic visit limit to 1 to 2 per month. Patient and family are involved in care, no need for needles or vascular access, and it's a steady state therapy and gentler ultrafiltration. But the disadvantages are what? It is permanent external catheter, no off days, every day you have to do, risk of peritonitis, risk of weight gain from glucose and disilate, must store dialysis equipment and supplies at home, and need for self-monitoring care, of course, in these patients, right? So, like this is how they do this. So now uh, this is how like they do the dialysis, right? And these two are of course like the types of RRT or renal replacement therapy. So now there are many complications of renal replacement therapies as well. Okay, complications are also there, of course, like because nothing can take what the original thing do basically, of course. So there are many complications of renal replacement therapy, and of course, like the patients, like there is mortality due to that as well. So, for example, many people they have hypertension, okay, and there is calcium and phosphate dysregulation is there, as well as like there could be what you can say uh, protein calorie malnutrition. There could be renal bone disease. Okay, because it's not like this. Like when we put like the patient on dialysis, we don't have to give any medications. Why? Because still the patients need erythropoietin injection. Still the patient need calcium supplementation. Still the patient need phosphate binders. Still the patient have to take care of what you can say um, the potential infection risk factors. The patient needs prophylaxis and things like this. And infections can occur. Okay, remember, like infections, I told you, and one of the thing is uh, amyloidosis can occur. Okay, so why? Because beta 2 microglobulin accumulates uh, in long-term dialytic patients. Okay, so this is how they perform this thing. And who are the people who need dialysis? I already told you, right? We check the volume of status, we check like the electrolytes, we check like either the patient have something like pulmonary edema, pericarditis and stuff like this. Okay, so that's the reason like um, we go for dialysis. And one of the type of the renal replacement therapy is of course transplantation, okay, or the renal transplant. uh, of course like when the patients they got this thing, they don't have to go for dialysis every day, but of course like this one is not everyone have the donors, or not everyone have what you can say the perfect matches. Okay, and in this world of course like there is a lot of less availability of the organs, and the people who are waiting for the transplantations are more. But transplantation, it should be considered for every patient. And as like someone is approaching to end stage renal disease, uh, uh, it gives best results when the patients they get transplants before going on dialysis, or without getting any blood transfusions. So now transplant can be considered in all the renal patient, except for example someone who have cancers with metastasis, or someone who have for example HIV, active HIV infection. So of course like we cannot give transplant in them. And the transplant can be coming from the living donor, or the transplant kidney can be coming from a diseased or a cadaver. Okay, diseased donor. And the first thing, the most important thing is, guys, if there is a big or good HLA match, or HLA means human leukocyte antigen, which is all previously it was called as major histocompatibility complex, MHC, right? So that's why the best result is when someone who is living and he's related to the first patient, if they will give, that gives the best results. Okay, so and of course, whenever it is disease, it is mostly taken from the brain dead people, in which the circulation is still going on. Okay, so they they take it from them. Uh, so of course, like they do a lot of pre-transplant. It's a topic of surgery, but it's okay. Like There is a lot of pre-transplant preparation, like checking the renal function of the donor, checking him from the infections, um, checking like what is the health of his other kidney, because if he's going to donate one kidney, so either he can live on the other kidney, and for how long they can live on the other kidney. So a lot of testings, they do. Then they do the blood group matching. Then they do the HLA compatibility test, and of course, like they do it uh, when the HLA or MHC have the best match or maximum matches there. So once, like, of course, like the transplant surgery is done, uh, uh, they put the patient on immunosuppression. Okay, and how to do immunosuppression? There are many drugs nowadays, okay, which are used for immunosuppression, and that's why there are good results of transplantation is done. So nowadays, like they give a combination of drugs, and of course, there are different type of rejections like hyperacute rejection, acute rejection, as well as chronic rejection. So, like hyperacute rejection can be avoided if we will do a good pre-transplant investigations. Acute rejection can be prevented by using these drugs, immunosuppression. But whereas the chronic rejection, we don't understand much about that. Okay, so that's why it could not be stopped. Uh, Nowadays, like of course, which is like the rejection which occurs after 7 to 12 years after renal transplant. So, of course, like most of the immunosuppressive drugs, they are nephrotoxic as well. So we give the low possible dose with, uh, you can say, low uh, side effects profile. Okay, the drug which is comparatively safe. Okay, and what are the drugs which are used? Like it could be monoclonal antibodies, like uh, there are many drugs like basilizumab, things like this. There are calcineurin inhibitors like tacrolimus or cyclosporin, or there are many anti-metabolic drugs, and there are many steroids or corticosteroids or glucocorticosteroids, okay, which are used. So collectively they are called as anti sorry immunosuppressive drugs, because what they are doing, uh, they are blocking the T cell functions. Okay, they inhibit the T cell activation and proliferation. Or drugs like azathioprine, which are also called as metabolite anti-metabolites. Okay, so like all of these drugs, they have like the same glucocorticoids. They decrease the inflammatory cytokines. So simply, we have to suppress the patient immunity as much as we can, because if we will not suppress that, of course the transplanted kidney can be rejected as a foreign body. So that's the reason. So there are many complications of this thing as well. Uh, for example, like there are complications related to surgery, or surgical complications can be there, like bleeding, uh, infection, damage to the adjoining structures, urinary leaks, thrombosis, hernias, and of course, like there could be uh, complications due to rejection. Okay, which could be acute or chronic. So acute or chronic rejection can be there, and of course, like acute is either antibody mediated or cell mediated. So cell mediated is the more common one, and uh, the chronic is mostly antibody mediated. Okay, so this thing, so infection can be there. Now we put the patients on immunosuppressive drugs. So malignancies. I remember when we suppress the immunity. So immunity is the one which protect us against the malignancies as well. So they are at the risk of malignancies. What you can say, there is increased chances of having heart diseases in these patients. Okay, the renal transplant patient. Nowadays, the results are better of transplant. Like there is uh, good survival uh, for the patients who get the renal transplant. But it depends on the factors. It depends on the donor age, donor comorbidity. Either the donor was living, or either the donor was dead, or either the donor was are related, or either a donor was not related, and depend on the patient condition as well. Like either the patient who was receiving the kidney was having any comorbidity or not, what is his general health and all this stuff. So it depends on a lot of what you can say factors on the survivability of the patient. Okay, so I think that's pretty much about this one. So I hope you understand this thing. So thank you so much, guys, for listening.